Hi there, my valued and treasured viewers and listeners, and welcome back to Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the health sector, your trusted partner in delivery of pharmacotherapy services. My name is Dr. Nath Arwa, and I am the founder of Progressive Pharmacotherapy Consultants. Now, at Pharmacotherapy Consultants, patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. We seek to remain at the forefront of partnering with you to ensure patient safety even as you deliver your pharmacotherapy services. So I urge you to sit back and spare me part of your precious time as I share bits and pieces of tips that will ensure you deliver safe services. So welcome to part 5 of our pharmacotherapy MCQs. So let's begin with case 1. In a cohort study of 47,363 male US professionals, the HPFS regular aspirin use, which amounted to either 2 or more times a week of intake, found an RR of 0.79 at a 95% confidence interval, 0.69 to 0.9 for colorectal cancer over 18 years of follow-up. So my question to you is, how can this data be interpreted? Is it 1, those who take aspirin more than or equal to 2 times weekly have a 0.79 times risk of colorectal cancer? Or is it 2, those who take aspirin 2 or more times weekly have a 0.21 times risk of colorectal cancer? Or is it 3, those who take aspirin 2 or more times weekly have a 21% lower risk of colorectal cancer? Or is it 4, those who take aspirin 2 or more times weekly have a 79% risk of colorectal cancer? So, would you choose 2 as your best option, or would you choose 2 and 3 as your best options, or would you go for options 1 and 4, or finally would you opt for options 1 and 3? I'll give you 10 seconds to make the correct choice, after which I'll display the answer that I consider correct in my opinion. So, in my opinion, D is the correct answer. And the reason why is relative risk can be stated as 0.79 times as likely as, or 0.79 times the risk. But it can also be illustrated as a relative risk reduction and stated as a 21% risk reduction or 21% lower risk by the medication. So let's move to the next question, which reads, LAM didn't receive the influenza vaccine prior to the start of this season. Now he dwells in the northern hemisphere. It is now December. He got the influenza vaccine last year. So My question to you is, which of the following is the correct course of action at the moment? Would you opt to skip the influenza vaccine for this year? Or would you skip the influenza vaccine for this year since he received the vaccine last year? Or would you ensure LAM starts on oseltamivir to protect him from the influenza infection? Or finally, option D, would you vaccinate him with the influenza vaccine since influenza season lasts until March in the northern hemisphere? I'll give you 10 seconds to make the correct choice. In my opinion, that option D is the correct choice. I would opt to vaccinate LAM with the influenza vaccine since the influenza season lasts until March in the northern hemisphere. Now, the influenza vaccine is recommended annually, thus LAM should not skip this year's vaccine. So answer B is incorrect. Now, according to the CDC, seasonal influenza outbreaks can occur as early in the northern hemisphere as October. However, most activity peaks in January or later. Thus, it's not too late for LAM to receive his vaccine in December. So that makes answer A incorrect. Lastly, antiviral medications such as oseltamivir are important adjuncts to vaccines. So that's just a reminder. Now, it's also recommended to administer these neuraminidase inhibitors as early as possible in patients with confirmed or suspected influenza who are either hospitalized or who have severe infection or who have complicated or progressive illness. And they are also highly recommended in patients who are at high risk of influenza complications. Thus, LAM is not a candidate with the given information, and I consider option C incorrect. So let's move to the next question, which reads, in the NHS cohort study, where those conducting the study looked at the association of regular aspirin use, which was 2 or more tablets of the 325 milligrams per week, and colorectal cancer in slightly over 82,000 women, found a relative risk of 0.77, the 95% confidence interval 0.67 to 0.88 over 20 years of follow-up. In another analysis of the NHS regular aspirin use, investigators also found a hazard ratio of 0.72, the 95% confidence interval of 0.56 to 0.92. So my question to you is, what does this say about the mortality for colorectal cancer? And how can this data be interpreted? Is it A, those who take aspirin more than 2 times weekly have 23% lower risk of colorectal cancer? Or is it B, those who take aspirin more than twice weekly have 0.77% lower risk of colorectal cancer? Or is it C, those who take aspirin over 2 times weekly have a 28% lower risk of colorectal cancer? Or is it finally D, those who take aspirin more than twice, or equal to or more than twice weekly, have a 23% reduction in death from colorectal cancer. I'll give you 10 seconds to make a rational choice from the 4. So I would opt for answer A. Now, the relative risk can be stated as 0.77 times as likely or 0.77 times of risk, but it could also be illustrated as a relative risk reduction stated as a 23% risk reduction or 23% lower risk by taking the medication. Now, in the same cohort study where they looked at the association of regular use of aspirin, that is at a dose of 2 tablets of the 225 milligrams weekly, and colorectal cancer in the same number of women over 22 years of follow-up. This time round, my question to you is, what does this say about the mortality from colorectal cancer, and how can this be interpreted? Is it those who take aspirin regularly have a 72% lower risk of colorectal cancer? Or is it those who take aspirin regularly have a 28% reduction in death of from colorectal cancer? Or is it those who take aspirin regularly have a 0.23% lower risk of colorectal cancer? Or is it finally those who take aspirin regularly have a 77% lower risk of colorectal cancer? I'll give you 10 seconds to make the correct choice from the 4. I would opt for option B. Hazard ratio can be used to compare time to event data between two groups. So in this case, the time to event was 20 years to death from colorectal cancer, and the groups were patients taking aspirin 325 milligrams 2 times or more weekly, and the patients that did not. So with hazard ratio being 0.72, the patients taking the aspirin were 0.72 times likely to die at any time during the 20 years. This means that aspirin had a 28% reduction in death from colorectal cancer. So we'll move to the next question, which reads, JM is a 72-year-old who comes or reports to the A&E with gastroenteritis. After reviewing his vaccination records, you establish that he has received 1 dose of Tdap when he was 60 years old. He had influenza vaccine and the PPSV 23 3 years ago when he was admitted in the hospital for an exacerbation of his heart failure. It is now October in the Northern Hemisphere, so what vaccines should JM receive, assuming he resides in the United States of America? Is it influenza vaccine, or should he receive the PCV13 and influenza vaccines, or should he receive Vaxigrip, the influenza vaccine, and PCV13 together with zoster and a TD booster. Or finally, should he receive a similar lot to option C plus the MMR? I'll give you 10 seconds to make the correct choice. So in my opinion, C is the correct choice. Influenza vaccine is recommended annually. Thus, Mr. JM is a candidate and he hasn't received the vaccine since 2013. He is also a candidate for herpes zoster vaccine as he is above 60 years of age. And Tdap booster is recommended every 10 years. Thus, Mr. JM is a candidate since he last received his Tdap 12 years ago. And lastly, he's a candidate for PCV13 vaccine as it is recommended 1 or more years after the PPSV23 shot, which he received like around 3 years ago, if I remember well. He isn't a candidate for MMR since individuals born prior to 1957 are considered immune to measles and mumps. So I would go for option C in this case. Let's move to the next slide. Now, which of the following would be the most appropriate to treat Cenotrophomonas maltophilia? Would it be meropenem or vancomycin administered over an hour, meropenem over 3 hours at a dose of 2 grams IV thrice daily? Or would it be 400 milligrams of ciprofloxacin administered at a dose of 400 milligrams IV over an hour thrice daily? Or would it be sulfamethoxazole and trimethoprim co-formulated and marketed as Septrin or Bactrim? I'll give you 10 seconds to make the correct decision. The correct answer is D. The primary treatment for Stenotrophomonas maltophilia is sulfamethoxazole trimethoprim. The other three do not cover this microbe at all. Let's move to the next slide. The rate that an outcome with a given particular exposure compared to the rate of the outcome occurring in the absence of that exposure is best defined as incidence rate, or is it prevalence rate, or is it odds ratio, or is it relative risk? I'll give you 10 seconds to decide which of the best of the four is the best option. Hope the statisticians in the house will agree with me that relative risk is the correct answer. So relative risk is the rate of an outcome occurring in an exposed group divided by the rate of an outcome occurring in an unexposed group. So in this case, the exposed group is the treatment group or the intervention group, and our unexposed group is the control. So let's move to the next question, which reads, JPO is a 68-year-old African American who presents to your clinic for his BP or hypertension management. His past medical history includes peptic ulcer disease and hypertension. His two BP readings are 160/98 and 159 systolic over 96, and the heart rate is 85. JPO says he takes clothalidone and Prilosec 20 milligrams orally once a day. Which of the following is the best strategy to manage his blood pressure? Is it increase the clothalidone dose to 25 milligrams daily? Or is it add amlodipine 2.5 milligrams orally once a day? Or would you add lisinopril 5 milligrams once daily? Or would you do both A and B? So I'll give you 10 seconds to make the correct therapeutic choice for JPO. In my opinion, both strategies A and B combined would work. Both strategies A and B would work for this gentleman. Since the patient is above 60 years old and he doesn't have CKD or diabetes mellitus, his goal BP should be systolic below 150 millimeters of mercury, or diastolic blood pressure below 90 milligrams of mercury. He isn't currently at this goal with his medication from what we have seen. So options are to maximize the current medication dose, option A, or to add a second agent. Since calcium channel blockers like amlodipine are recommended as initial treatment options in the African American population, choosing amlodipine over lisinopril would probably be a more effective option. So I would settle for D. Let's move to the next slide. Results from a meta-analysis where those conducting the study looked at the frequency of postoperative AFib in patients on ascorbic acid after cardiac surgery found an odds ratio of 0.44 with a 95% confidence interval 0.32 to 0.61. So how can you as a statistician interpret this data? Does it imply that ascorbic acid increased the frequency of postoperative AFib after cardiac surgery by 44%? Or does it infer that it decreased it by 44%? Or does it mean there was no statistically significant difference in frequency of postoperative AFib after surgery? Or finally, does it mean ascorbic acid decreased the frequency of postoperative AFib after cardiac surgery by 56%? I'll give you 10 seconds to make a rational decision. So in my opinion, D is the correct answer. Odds ratio of 0.44, 44% means that this group was associated with an event happening 44% of the time compared to 1 of the time if unexposed. Therefore, 100 minus 44 gives you 56%, which is the reduction caused by the exposure. Now, exposure in this case is the use of ascorbic acid. So let's move to the next slide. The management of adults with hospital-acquired and ventilator-associated pneumonia, 2016 guidelines by the IDSA and the American Thoracic Society recommends covering which bacteria empirically for suspected VAP? Is it Staphylococcus aureus and Pseudomonas aeruginosa, or is it Streptococcus and Pseudomonas aeruginosa, or is it Pseudomonas aeruginosa and the extended spectrum beta-lactamases, or is it finally S. aureus and the Streptococcus species? I'll give you 10 seconds to make the correct decision. Correct answer is Staphylococcus aureus and Pseudomonas aeruginosa. These bacteria are some of the most commonly associated pathogens with VAP. And this is based on surveillance data from the US. They are also some of the most frequent isolates identified in international surveillance programs as well. Therefore, the guidelines recommend we cover for them when patients experience VAP. So that makes A the correct answer. Let's move to the next slide. So HPB is a 46-year-old African American with a history of CKD due to radio contrast media. His 2 average BP readings is 157 systolic, 94 diastolic. His heart rate at the moment is 65. His CBC and complete metabolic panel are within limits, except his serum creatinine, which is 1.6. Which of the following is the best way to manage his hypertension according to JNC 8? Would it be lifestyle modification? Will it be lifestyle modification plus lisinopril at a dose of 2.5 milligrams daily? Or would it be lifestyle modification plus amlodipine 2.5 milligrams daily? Or would it be lifestyle modification plus metoprolol succinate 25 milligrams orally taken once a day? I'll give you 10 seconds to make the correct choice. I would opt for option C, a lifestyle modification plus low dose amlodipine. I would initiate him at 2.5 milligrams orally once a day. So this patient is below the age of 60. He's African American and he has CKD. So in this case, the goal BP should be systolic below 140, diastolic below 90. Option B isn't the best choice because ACE inhibitors like lisinopril can worsen serum creatinine. Remember, it's already at 1.6. His heart rate is already on the lower end of normal, and the range is usually 60 to 80 beats per minute. So adding metoprolol succinate wouldn't be a good idea. So option C is our best one in this particular case. Let's move to the next slide. Now, the number of new cases per population at risk at a given time defines one of the following. Which one is it? Is it incidence rate? Is it prevalence rate? Is it mortality rate? Or is it odds ratio? I'll give you 10 seconds to make the correct choice. So, in my opinion, the correct answer is A, incidence rate, which can be calculated by dividing the new reported cases by the summed person years of observation. Now, prevalence would be calculated by dividing the cases in that population in a given period by the total population at that time. And mortality rate would be calculated using the formula deaths during specified time interval divided by population size at risk of death. So let's move to the next question. BOZ is a 48-year-old woman who presents to your A&E with vertigo, nausea, and vomiting after eating food from the previous night. She denies any focal numbness, tingling, or weakness. She has experienced some unsteadiness and dizziness throughout the day prior to presenting to the A&E. Her past medical history includes multiple sclerosis, hypertension, diabetes mellitus, and hyperlipidemia. MS has been stable on glatiramer acetate for the past 7 years since she was initiated on the same. So, what is the treatment choice for her MS exacerbation during this visit? Would it be Solumedrol 250 milligrams infused daily for 4 days, followed by an oral taper of prednisolone? Or would it be methylprednisolone 1 gram infused daily for 5 days, followed by an oral taper with prednisolone? Or would it be methylprednisolone 250 milligrams infused daily for 4 days and that's it? Or would it be 1 gram of methylprednisolone infused over 5 days and that is it without a taper? So I'll give you 10 seconds to make the correct decision. So in my opinion, answer D is correct. Now, a literature review of the management of MS exacerbation treatments concludes that IV steroids are the preferred route of administration. High-dose IV Solumedrol methylprednisolone, varying from 500 milligrams to a gram for 3 to 5 days, has proved effective in many studies. Oral steroid tapers have no supporting evidence in the literature available. So I would go for D. Let's move to the next slide. Which of the following diagnostic laboratory tests is recommended by the management of adults with HAP and VAP 2016 guidelines by the IDSA and by the American Thoracic Society, in addition to clinical criteria to guide discontinuation of antibiotic therapy? Is it procalcitonin? Is it C-reactive protein? Is it CPIS? Or is it clinical criteria alone? I'll give you 10 seconds to make a decision. So I would opt for procalcitonin. The use of PCT levels can decrease antibiotic exposure without increasing treatment failure or causing increased mortality. As a result, treatment costs as well as the occurrence of side effects are reduced when we employ this option. Now, current evidence doesn't support the use of CPIS to guide discontinuation of antibiotic pharmacotherapy in such patients, since it isn't reliable enough to determine whether antibiotics or antibiotic therapy should be continued or not. Now, CRP wasn't mentioned in the above 2016 guidelines as to whether they can determine discontinuation of antibiotic therapy or not. So that leaves us with A as the correct option. Let's move to the next slide. So KHR is a 69-year-old male with a medical history of diabetes mellitus, hypertension, and hypercholesterolemia. His fasting lipid profile is TC 530 milligrams per deciliter, LDL of 125, HDL of 48, total TG of 640, and the A1C is 8.1. The calculated creatinine clearance in this case is 65, and the BP is systolic 135, diastolic 80. The heart rate is 70 beats per minute. The current medications include 1 gram of glucophage or metformin taken orally twice a day after meals, 20 milligrams of lisinopril taken orally once a day. He's also on sitagliptin, 50 milligrams taken twice daily alongside the metformin, and atorvastatin, 20 milligrams taken orally at bedtime. So what is the best pharmacologic agent to initiate in the case of our patient KHR? Would it be increase his atorvastatin dose to the high intensity dose of 80 milligrams orally at night, or would you opt for niacin 500 milligrams twice daily orally, or would you introduce fenofibrate at a dose of 162 milligrams orally once a day, or would you add to his regimen gemfibrozil at a dose of 600 milligrams BD? I'll give you 10 seconds to make the correct choice. In my opinion, option C would be our best approach. It is reasonable to add triglyceride lowering medications such as the fibrates or niacin to prevent pancreatitis in patients with triglyceride levels above 500, which applies to our patient because his TG, according to the text, is 640, if I remember well. Now, answer C is wrong because gemfibrozil should not be initiated in patients on statin therapy. Remember, he's already on a statin because of an increased risk of muscle symptoms, and in extreme cases, rhabdomyolysis may occur. Fenofibrate may be considered concomitantly with low or moderate intensity statins when the triglyceride levels are above 500. For niacin, the dose should start at 100 TID. And another point is that niacin does not lower triglyceride levels as much as fibrates do. Fibrates are superior to it. Now, fenofibrates are dose adjusted for renal patients, such as our case here, but this needs to be monitored for any symptoms of muscle pain that may be experienced by our patients, as is that he is at a higher risk due to being diabetic. So I would settle for C as my best option. Let's move to the next slide. So GOS is a 71-year-old man. He weighs 253 pounds and is 5'11". The past medical history includes gout, he eats a lot of red meat, hypertension, dyslipidemia, COPD, and when you put him on sitagliptin, he experienced pancreatitis. His BP is 138 systolic, 88 diastolic, A1C is 9.4, and the kidney looks okay. Serum creatinine is 1 at the moment. His current medications include metformin, a gram, taken orally twice a day. He also administers insulin glargine as his basal alternative at a dose of 30 units at bedtime. He is also on an old drug, acarbose, which he takes 100 milligrams at mealtime thrice a day, and he's on high intensity statin, atorvastatin, 80 milligrams at bedtime. He also takes ramipril 10 milligrams orally once a day, and for his COPD he receives or takes or inhales tiotropium 18 micrograms once a day. Now, which of the following would be the most correct option for the management of his type 2 diabetes mellitus? Would it be adding empagliflozin 10 milligrams orally once a day, or would you introduce exenatide administered subcutaneously at a dose of 2 milligrams once a week on Mondays, or would you add 5 milligrams of linagliptin orally once a day, or would you increase his basal insulin to 60 units and introduce insulin lispro sliding scale? So I'll give you 10 seconds to make the correct decision. So in my opinion, answer A would be the most ideal option. I would add empagliflozin 10 milligrams orally once a day to this patient's regimen. Now, linagliptin isn't an option since in the text we are told there was an issue earlier when he was on sitagliptin, a drug from the same class, and it caused some kind of pancreatitis. So I would not go for option C. GLP-1 antagonists are also associated with pancreatitis, so exenatide wouldn't be recommended either. I would skip option B. Now, increasing his basal insulin and adding a bolus isn't appropriate either, since sliding scale in people of his age appears on what we call the Beers list, due to potential increased risk of hypoglycemia in this particular patient. So I would be very reluctant to increase his Lantus dose and add the Lispro at this stage. So I would settle for option A as my correct option. So my esteemed viewers and listeners, it was a pleasure making suggestions on how best to tweak your pharmacotherapy for optimal outcomes in your line of duty. And if this video helped you in any way, I would urge you to remember to give it a thumbs up and to subscribe to my YouTube channel. I promise you better things to come, and I'm very thankful you made time to listen to and to watch this video. I look forward to interacting with you in the next edition. So thank you very much for making time.